Hi, I'm Sophia Fu. I'm a fellowship trained, board certified breast surgeon, and I'm the director of breast surgery here at Good Samaritan Hospital. Today I'd like to talk to you about an update on breast health. This is just a summary of the statistics of breast cancer in the U.S. 1 in 8 women will develop breast cancer in their entire lifetime. That's roughly a 12% risk. In this year of 2020, about 276,000 women will be diagnosed with breast cancer this year, and about 42,000 are expected to die. That represents about 7% of all deaths. Breast cancer actually comprises of about 15% of all cancers out there in the U.S. today. We know it is the most common cancer in women, and also is the second highest cancer death rate in women. But despite this, the breast cancer rate continues to decrease. So if you look at the bottom part of the slide, if you look at the 5-year survival rates back in the 50s, it was roughly 60%, and nowadays it's over 90%. So we've done really well in the treatment of breast cancer. So much so that we actually have 3.5 million survivors in the U.S. today. So where do we begin? Well, breast self-awareness is the first thing. So we should really know about what sort of changes to look for in our breasts. If there's any sort of texture change or dimpling, those are little red flags to perhaps see your physician a little sooner. Any sort of masses in your breast or your armpit, any sort of discharge that's coming out of your nipples, or if the nipple becomes inverted, and any sort of redness or rashes on the breast. The next important thing is screening. And so mammography is the way that we screen the breasts. And it can be a little confusing out there because there are several different societies and organizations that recommend different ages to start screening. I like to focus on the American Society of Breast Surgeons, which is one of the largest societies of breast surgeons. In fact, most breast surgeons are part of the society in the U.S. And they came out with some guidelines several years back. And so starting at the age of 25, all women should really undergo a formal risk assessment. So that's trying to figure out what is your risk for breast cancer. So it'll stratify you either into an average risk for breast cancer group or a higher than average risk for breast cancer group. If you're at average risk, the recommendation is really to start that yearly screening at age 40. If you fall under that higher risk group, then you should start a little bit earlier, but really it depends on a risk-based age, and also be offered some supplemental imaging such as MRI. There's always the question of, well, when should we stop screening? And the recommendation is if your life expectancy is greater than 10 years, you should continue screening. But if it's less than 10 years, then perhaps maybe you don't need to get any more mammograms. So Are You Dense? That is a big campaign several years back for women to know what their density is. And what is breast density exactly? So this is a very good description by the American Cancer Society of what is dense breast tissue. And so the breasts, as you can see in this picture, are composed of lobules, ducts, fatty tissue, and fibrous connective tissue. And so the lobules at the end of the ducts are what produces the milk, and they're called the glandular tissue. And then the ducts are those tiny little tubes that connect your lobules to the nipple so that the milk can be expressed into the nipple. And then the rest of the breast is composed of fibrous tissue as well as fat that sort of give the breast their shape and their size and kind of hold all the other stuff into place. And so people that have dense breasts are actually people that have a lot more of the fibrous and glandular tissue. And there's not a lot of fat in there. Breast density generally doesn't change over time, but in some people you could become less dense with age. And so the next picture is a very good description of what the different densities are. And so this is from the American College of Radiology, and there are 4 categories, A, B, C, and D. So if you look all the way to your left, A is very fatty breast. It's called entirely fatty breast. And the fatter areas are more darker. The whiter elements are that fibrous glandular tissue. And you could see in category A, there's very little white tissue, and it's mostly dark. And then on the other extreme, in category D, that is extremely dense breast. And over there, you can see there's a lot of white tissue. It makes it very difficult to look for things. And that is called extremely dense tissue. So the majority of people are somewhere in between. But what is the significance of dense breast? Well, if you have dense breast, so that's considered category C and D, there is a slightly higher risk for breast cancer than people that have non-dense breasts, which are categories A and B. Also, it makes it difficult to diagnose a breast cancer sometimes because breast cancers are always also white, and it's kind of like looking for a snowball in a snowstorm in very dense breasts. So that is why we use some sort of supplemental imaging such as ultrasound. And the ultrasound is very helpful for looking at the breast tissue in another way so that we may be able to detect even more things that could be going on that might be missed on mammography. Next is MRI. MRI is a great study. It's a great adjunct to screening mammography, but we really save it for the high-risk patients. That's because there is a very high false positive rate, meaning that oftentimes we find things that might be suspicious, they get biopsied, and a lot of times they're negative. So we really save it for people that are higher risk, and that's been designated as a greater than 20% lifetime risk of developing breast cancer, because there's more likelihood that we'll find something that might actually be something. It's also particularly helpful for breast cancer cases, especially in complex cases, to sort of figure out the surgical plan. So what can you do to lower your risk of breast cancer? Well, there are modifiable behaviors. So maintaining a healthy BMI is really key. You want to get that less than 25. The BMI calculation is based off of your weight and your height. And this can be maintained through a healthy diet as well as regular exercise. This is very key. Also, stop smoking. And if you don't smoke, don't start smoking. You want to also limit your alcohol consumption to less than to roughly about 2 to 3 drinks per week. This is a great article actually on breast cancer survivors. And so they looked at the effects of aerobic and resistance exercise on metabolic syndrome, which is associated with a high risk of cardiovascular disease as well as type 2 diabetes and breast cancer recurrence, as well as obesity and looking at circulating biomarkers. And what they found was increasing your aerobic and resistance exercise by actually getting a green prescription actually can help decrease all of that. And so what are ways to increase your physical activity? I know it's been very hard these days with the COVID-19 pandemic, but if you are out and about, definitely try to use the stairs instead of the elevator. That'll just increase your activity overall. You might want to consider walking or biking to your destination. Maybe instead of phoning a friend or emailing, take a walk to their house if it's nearby. Just stay socially distant. Also, you may want to grab a friend or a coworker or family member on your exercise ventures. You can also try to put in a little 10-minute exercise break during the day. So whatever you're doing, you can do a little stretch for 10 minutes or walk around the block or, up and down the office just to kind of get active and moving a little bit. Definitely wear a pedometer every day and try to maintain a step goal that you're going to try to achieve and keep watching it throughout the day to see if you hit that goal. And if you're at home watching TV, as a lot of people are these days, try using a stationary bike. That may be helpful to increase your activity, especially as the weather is getting worse. Now, this was a great study looking at yoga and its impact on inflammation, mood, and fatigue in breast cancer survivors. And so the patients were stratified into 2 groups, but the exercise group, they did 2 90-minute sessions of hatha yoga classes each week, and they studied them and looked at their inflammation factors, looking at their mood and fatigue, and they found that they did a lot better. They had more vitality and decrease in the inflammation. So now we sort of move into what should you look for when you're trying to find your breast care team. And so the breast surgeon is really the person that is following you and is the main point person who is helping to coordinate all your care and examining you year after year, and sometimes more frequently. So what are some of the reasons why you might see a breast surgeon? Well, if you have a high-risk lesion, if you've ever heard of atypical hyperplasia or LCIS, these sort of things, you would be seeing a breast surgeon. If you have any sort of masses in your breast or your axilla, if you have come across as high risk for breast cancer using any of the risk models that are out there, like we said earlier, greater than 20%, that would be a reason why. If you have a family history of breast cancer, or if you have a known genetic mutation, as well as if there's any sort of abnormal breast imaging, or if you have dense breasts, and of course if you have breast cancer or a history of breast cancer. So you do want to go to a comprehensive cancer center where you have multiple specialists that are on your side to help take care of you. And this breast care is really best performed in a multidisciplinary approach. And so here at Good Samaritan Hospital, we have specialists in every field. And every week we have a tumor board where all of the specialists meet to discuss the cancer care. So that's your breast surgeons, your medical oncologists, your radiation oncologists, your radiologists, your pathologists, geneticists, plastic surgeons, nurse navigators, social work, nutritionists. We're all gathered together to really figure out what is the best plan for you so that we can give a very personalized approach to breast cancer care. Also looking for designations such as NAPBC, which is the National Accreditation Program for Breast Centers, as well as the Commission on Cancer accreditations. They really strive for improving the quality care and outcomes in those with breast diseases and breast cancer. And so Good Samaritan Hospital year after year has been reaccredited with these designations and has been one of the first breast health centers on Long Island actually to achieve this. You also want to inquire about any clinical trials that might be available to you. So next I want to segue into what are surgical options if you do have breast cancer. And so traditionally mastectomy was the way to treat breast cancer, and that was removing the entire breast and sort of having a very flat chest wall. But since then we've been able to do reconstruction and spare the skin to be able to make the shape of a breast again, and even so much so a lot of patients are able to undergo what's called nipple-sparing mastectomies. So we're able to spare your nipple areolar complex and sort of give you the look of a real breast again. And the incisions are hidden very well, so you could actually barely tell that you had surgery. This is achieved through reconstruction, either using an implant or using your own tissue. And making sure that you have a microvascular surgeon available that might be able to do these free flaps like the DEEPs can be very advantageous for some. So you can imagine sometimes this reconstruction can be performed at the time, your final reconstruction can be performed at the time of your breast cancer surgery. And imagine just waking up and seeing that you have two breasts still. It's almost as if you've never even had surgery. So it's quite amazing. Now, not everybody needs to have a mastectomy. There is a very big push to try to conserve breasts if we're able to, and a lot of people are able to undergo breast conservation surgery. So what that means is you're essentially doing a lumpectomy, meaning taking out a portion of the breast and saving the rest of your breast. Now, this is usually done in conjunction with radiation. And sometimes you can have a little bit of changes with the radiation, so the cosmetic outcome isn't as great as sometimes. But there are techniques called oncoplastics in which breast surgeons have borrowed some techniques from our plastic surgery colleagues and are able to move tissue around to sort of reshape the breast and sort of give you a look of a whole breast again. And this has really been a game changer in the way we treat breast cancer. Next, I want to segue into lymphedema. So at the time of your breast surgery, you usually have to have surgery on your lymph nodes in your axilla, because that's usually where the breast cancer would drain first if it's gone anywhere in the local area. And one of the side effects of any sort of axillary surgery is lymphedema. Lymphedema is sort of a disease process of swelling of your arm, and that usually arises because there's an injury to the axillary lymphatics that are that lead from your arm to the rest of your body. This can happen during a lymph node dissection. And so the picture here sort of shows the different lymph node basins and where the lymphatics are coming from. Now, cellulitis is the most common risk factor, is the most important risk factor for developing lymphedema, but also elevated BMI. So this is kind of a theme that we've been talking about. So once you've developed lymphedema, really early intervention is very key. If you have cellulitis, you want to start antibiotics. You want to perform some arm exercises and be under the guidance of a physical therapist specializing in lymphedema, which we do offer at our sister hospital. Compression garments may be worn, and the majority of people who develop lymphedema after axillary surgery will develop it in less than 3 years. This was a great article about weightlifting and women at risk for breast cancer-related lymphedema. And following these patients after a year of weightlifting intervention versus no exercise, they actually had improvement, a decrease in the amount of lymphedema rates in those that did not do the weightlifting. So there are strategies to sort of decrease the lymphedema. We're constantly reassessing what can we do to improve this. And so we continually try to figure out who are the people that we could try to avoid axillary surgery if possible. There are some choosing wisely guidelines that were published by different societies, such as the Surgical Society of Oncology and the ASBRS, in which certain elderly patients may be able to avoid lymph node surgery. We're constantly looking at whether radiation may be a better option than surgery for certain cases, because the rate of lymphedema is much less with radiation than surgery. And there are some techniques such as axillary reverse mapping that pretty much I have adopted for all my patients, and that is mapping out the lymphatics coming from your arm. And so you can see that in blue, those are the lymphatics coming from the arm. We're trying to map out the ones coming from the breast, and we're trying to avoid the ones from the arm. And when we do this, we found that the lymphedema rate at 2 years was significantly decreased from about a third of patients who can get lymphedema, only about 5% developed it. And we are actually participating in a clinical trial here at Good Samaritan starting next month on axillary reverse mapping that I will be the principal investigator on. Now, there's some additional things that have been sort of in the forefront of breast cancer care these days, and that is potentially doing a prophylactic surgery to prevent lymphedema from happening. So what is called lympha, it's a lymphatic microsurgical preventative healing approach. And basically you're making little connections in your axilla from the lymphatics, connecting them to small blood vessels like the venules at the time of your axillary lymph node dissection to hopefully avoid lymphedema from happening. This was first described by Francesco Briccardo, and the lymphedema rates were significantly lowered by doing this. And this is something that we actually have started doing here at Good Samaritan in the last couple of months and plan to continue. So in conclusion, breast self-awareness is very key. Also seeing a breast surgeon for a risk assessment to see when you should start screening. Getting screened is very important, and that should be done annually at least. And seeking care at a comprehensive cancer center, as well as inquiring about the spectrum of surgical techniques that are available and asking for clinical trials. So with that, in conclusion, this is just my contact information. I see patients both at the Cancer Center, Cancer Institute at Good Samaritan Hospital, as well as Mercy Medical. And there's my number. If you need an appointment, I'd be happy to see you. And thank you very much today.